Good evening, everyone. On the behalf of Team DentistChannel.Online, I would like to extend a very warm welcome to all. I'm Dr. Aditi Mishra, and I'll be the host for today's session on the topic TMD diagnosis, a myriad of controversies by Dr. Megha. So before starting on the session, I have few housekeeping notes to make. If you have any query, any doubts during the session, you can ask by mentioning or by putting your question in the question and answer box in your control panel, and each and every question will be taken up at the end of the session. If you have joined us from Facebook and YouTube Live, you can ask us questions by commenting, and each question will be answered at the end of the session. So without further ado, I would like to welcome our today's speaker. So just quickly, I'll be introducing Dr. Megha to everyone. Dr. Megha is the BDS Gold Medalist and MDS Oral Medicine and Radiology. She has done MDS from Triveni Institute of Dental Sciences, Hospital and Research Center, Bilaspur, Pandit Deen Dayal Upadhyay Memorial Health Service University, Raipur, and she has done her BDS from the same college in Triveni Institute of Dental Sciences, Hospital and Research, Bilaspur. She has been the gold medalist during her BDS session 2012-2016. She is the topper of the year in the Nasia Dental Conference. Academic achievement, she has received first prize sold 2017 Triveni Dental Hospital. So over to you, Doctor. Can you hear me?
Yeah. Thank you so much. Hi, Dr. Aditi, and it's a huge, it's an opportunity for me to be present over here in the Dentist Channel Online. Yes, thank you so much. Whatever you have said is a little introduction about me. So today, the basic topic of my discussion is no more jaw clicks. Before sharing my screen, I would just like to ask all my audience, do you people understand about temporomandibular joint disorders? Yeah, good evening. Yeah, temporomandibular joint disorders. To be very frank, this temporomandibular joint disorders are it's actually a myriad of controversy. Being an oral medicine specialist, we daily come across cases like these. We daily come across cases, and when we see the patient showing us symptoms regarding pain in the temporomandibular joint region area, or they have occlusal deformities, and they keep on asking the basic cause of the pain. On studying in depth, like in my post-graduation curriculum as well, on studying in depth, I tried to understood, and I just made out, and of course based on my experiences, I've just made out that this temporomandibular joint is actually a myriad of controversies. It has kept all of us in a strategic limbo. Actually, we are normally as a dentist we would say that yes, humko thoda bahut, we can give the patient normal sorts of treatment, but actually to understand the depth of the temporomandibular joint disorder is actually a great controversial topic. Today I'll just prove how it's a controversial topic, and moreover what are the challenges being a diagnosis specialist face on proper and prompt diagnosis of temporomandibular joint disorder, and also how to go through these issues which we face during diagnosis, and also help the patient get cured and get rid of temporomandibular joint disorders easily. So this is a very unique joint, as everybody knows, and I hope the people have joined here, and most of them are dentists. Everybody knows, yes, there are people, yes, OMR, yes, I know. Okay, so there are people who know what exactly it is based on. But yes, today I'll be proving it, and I'll be taking it through the roadway, and then you'll be understanding, according to whatever knowledge I have, how it is a controversy actually. So when I talk about temporomandibular joint disorders, it is a very complex joint. It's a very unique joint. Why it is a very unique joint is we are not able to classify it. We are not able to put it under orthopedics. It is not a joint which can only be cured by oral surgeons or oral medicine specialists. It is also not a joint which can easily be cured by otorhinolaryngologists, that is ENT specialists. All right. So It is also not a joint which can only be cured by physiotherapists. So when I talk about treatment of temporomandibular joint disorders, of course, it is a controversy in its etiology. There are many, physiological and pathological evidences which can lead to these disorders. We have ample of classic features which I'll be showing today. The dangerous 13 knockout features, which is alarming towards your temporomandibular joint disorders, and also the treatment modalities related to it. So we are still in a strategic limbo. So let's go through the presentation and make you people aware whatever knowledge I have and how I would like to prove it. Anyways, so the basic topic of my presentation is no more jaw clicks. Why did I keep it as a topic of my presentation is the first and foremost symptom which a patient tells me, which first and foremost problem which a patient comes up with a TMD is he or she is having jaw clicks. And this is like sometimes the patient may be suffering from severe issues related to jaw clicks, and sometimes it's like they are not facing any difficulties apart from normal clicking in their temporomandibular joint area. So let's go through how it proceeds. So it's a very simple joint. It's also a very unique joint. It is a very unique joint. The reason behind this is it functions as a bilateral joint. Like the right and the left joints, they function in pair. Apart from that, it has a classic cartilage present in between it, that is the hyaline cartilage, which is definitely an exception because her joint ke beech mein fibrocartilage is present hote, but hyaline cartilage is present in this particular type of joint. Moreover, it has specific receptors depending and pertaining to different hormonal receptors which can lead to the etiology of TMDs. So it is a very unique joint. Apart from that, why is it a controversy? Now, controversy is a part of nature of art and creativity. Whatever is unique definitely serves itself as to be a controversy, right? It's a nature of art and creativity. Whatever issues we face is just because whatever classic features we have in the temporomandibular joint. It's anatomical. What are the basic parameters which help us understand that whether it is actually, what are the features which actually lead to the temporomandibular joint disorders? This is because of the anatomy of the joint, the physiological property of the joint. Apart from that, the pathology which can be related to it, and apart from that, we have different functional mechanisms. And this functional mechanisms not only deals with the normal functioning of the joint, it also deals with the other craniomandibular structures on the face and the occlusion of the face, which also pertains to the TMDs. Now, as we all actually know, this is a very simple slide which is showing actually why it is making TMJ as a very unique joint, as I've already told. This is a simple structure of the temporomandibular joint, which is showing how the temporal bone and the mandibular bone is articulating together with the articular disc present in between. And we have several other muscles which are accompanying it. We have capsule which is accompanying it. We have the retrodiscal tissues which are supplying blood supply. We have different blood vessels and ligaments which are holding our temporomandibular joint together. So it's making it a very complex structure and very interesting for us to go through. Now proceeding with the different type of controversies related to the etio-pathogenesis. Now, when I talk about the controversy related to etio-pathogenesis, I would definitely like to take through the history. We had several medical specialists who had given their contribution to make us understand what temporomandibular joint disorder is. To begin with, in the beginning, we had the temporomandibular joint syndrome or the myofascial pain dysfunction syndrome. We used to call it as craniomandibular syndrome. This was given up by different scientists, and everyone had put their views according to it. And I'll be explaining what are the different views and what is the actual etio-pathogenesis which we follow today, and how much depth we have gone to it. So the first was our Sir Daniel Laskin. हम सब डेंटिस्ट हैं इस पेज में, हमें कई लोगों ने Laskin की बुक भी पढ़ी होगी. So Laskin had explained that the temporomandibular joint disorders are basically pertaining to the muscular structures related to it and the craniofacial structures and craniofacial bones which contribute to the TMDs. So Laskin had given a view that अगर कोई भी बीमारी related to the temporomandibular joint होती है, so that is basically because of the joint structure and of course a bit of occlusion which is helping to initiate the temporomandibular joint disorders. Then came Dr. James Costin. Yes, he had given the era of Costin. He had given an era, and we used to call it Costin era. In the pre-Costin era, we used to believe that it is just the bones which cause TMG disorders, but no. In the post-Costin era or after the Costin era, we got to understand that there are multiple causes which lead to the temporomandibular joint disorders. We have the muscles, we have the vertebra, we have the ear, we have several other craniomandibular structures apart from the temporomandibular joint, which lead us to the temporomandibular joint syndrome. Then McCallum had given the nathological concept. He had given a concept in which he stated that this temporomandibular joint is not only related to the bone structures confined and localized to our lateral part, but yes, we have the other structures of the skull as well, which are involved. We have the styloid process. Okay, we have different, we have the ears, we have the ear bones, which also contribute and give us symptoms and take us in limbo regarding the temporomandibular joint disorders. Then we have Dr. Bernard Jangelson, who had given a concept of the myomotor concept, which we also call it muscular concept. According to him, we have several types of muscles, whether it is muscle of mastication, or we can also take up other secondary muscles and accessory muscles, the facial muscles, which are continuously in support of creating some sort of problem in the temporomandibular joint. If it is little bit also hampered, if it is not able to get proper blood supply, if it is hypoxic, or there must be any sort of inflammation which might start, which we often turn and they say it's myositis. There are different inflammatory response to the ligaments as well. So he had given a concept which was only pertaining to the muscles, and he had also said that 98% of the cases of temporomandibular joint disorders are basically due to the muscular activity. Then we had a concept given by Farrar and McCarthy. He had his concept stating that it's just the derangement of the distal tissues, that is the articular disc, which is responsible for creating absurd conditions in our temporomandibular joint. Of course, we have studied how the conditions take place, how when we open our mouth, the disc moves in front, how when we close our mouth, the disc goes back, what are the ligaments which catch hold of the articular disc, pulling them in front or at the back. So any derangement related to this articular disc is basically responsible for the temporomandibular joint disorders, according to respective Farrar and McCarthy. So we are able to find out there are so many etio-pathogenesis which are leading for the diagnosis. Apart from that, Dr. Gell, he had given simple diagnostic etio-pathogenesis, that is a condylar repositioning. He had told that whatever condyle is going to create in the temporomandibular joint, that is the basic result of the TMDs. And that condylar repositioning would be definitely the result of the malocclusion which we have in our teeth. So basically, according to Dr. Gelb, occlusion played a major role in creating the temporomandibular joint disorders. Apart from that, AD organized conference meetings and they gave a multi-dynamic approach. Yes, not only the views given by Laskin sir or Sir Dr. James Costin or McCallum or Bernard Jankelson or Farrar and McCarthy or Dr. Gelb. The concepts given by all were somehow or the other responsible, giving it a multidisciplinary approach and making us understand the disease, making us understand the disease in a more complex way. So he gave, it was a multi-dynamic approach given, and also people from different specialities were required to treat the temporomandibular joint disorders completely as a disciplinary approach. Now, in the recent times, and how our medical and the dental sciences are proceeding, we have the molecular level of pathogenesis also. It has given a multi-complexity of the causes. Whatever causes was stated by the different scientists in the history, all was proven by the molecular level of the pathogenesis, and still research is being going on, and still we are facing, and we have to, come up with the proper diagnosis and understand how this controversy can be resolved. So whenever a patient comes in our clinic or in our hospital, wherever we work, and presents with symptoms of temporomandibular joint disorders, there must be a multidisciplinary approach which should run in our brain, which should comprise of the bones, of the muscles, of the skeletal structures, of the complete movement and derangements of the discal tissue, of the occlusion of the patient, of the structure of the tooth, of the conditions which are there prevailing in the mouth, and then to come to a proper diagnosis, and then come to a reason of the diagnosis, and then proceed for the treatment. So it's not an easy disorder which has to be cured. So still on a battlefield, it can be resolved. Now I'll be showing how it is going to get resolved. Yeah. So we had done the controversies in the etio-pathogenesis. Still on a battlefield, let's get it resolved. So this is my TMJ. It of course hurts me. So just in the previous slide, we got to know it's not just the bone, it's not just the masticatory muscle, not the ligaments, blood supply, teeth. It is anything from among these which can hurt the TMJ. So it can get hurted by the teeth, by blood supply, by ligaments, masticatory muscles, bones, etc. So to give a very simple concept and very theoretical concept, these are the basic causes which lead to the temporomandibular joint disorders. It could be the chondrocyte initiation process. This is a of course inflammatory process in the molecular level of pathogenesis. The basic etiology can be due to the trauma. It could be hormonal pathogenesis, because as I already said, it's a very unique joint which has hormonal receptors, especially estrogen receptors, bromotryptane, dopamine receptors on it. Alteration in the extracellular matrix, of course, which can lead to several ligamentous and retrodiscal pain in the patients of TMJ disorders. So now, if it is measured, it's a fact, otherwise it's an opinion. Okay, so whenever a patient drops up in our clinic having pain on the face or on the temporomandibular joint area specifically, suffering from plaque, or of course having some or the other systemic disease involved, definitely it's temporomandibular joint disorder and should be cured and taken in that part of consideration. So see that these are the few dangerous 13 knockout features. Yes. So these features are somehow or the other related to the TMDs, and might also be confusing features which can lead us landing up in confusion, thinking that it's a TMD or any other symptom. The first and foremost is the pain in the TMJ, very common, facial pain. The patient may face facial pain in the area. It could be right, it could be left, it could be bilateral, which also might help us understand whether it is TMD pain or any other disorder. Ear noise and tinnitus, very common, because due to inflammatory processes, there might be some of the other inflammatory exudate which might flow into the eardrum and tympanic area, and the different nerves might get tingled, giving us ear noise and tinnitus. Deviation and deflection of the mandible at the opening, very common. I guess somebody has asked a question also, which will be coming up in the end. Of course, joint sounds, clicking, locking of the joint at opening or closing, very commonly. This feature, as I have clinical experience, I've seen patients having this issue. Those who have gone have had orthodontic treatment, they have had a locking of the joint and opening or closing, because some of the other occlusion or malocclusion which they were facing in history had led to the TMDs. Neck and shoulder pain, these are radiating pains. Headache, of course, this is a very common symptom which the patient might show in case of TMDs. Vertigo, Occlusal disharmony, yes, one of the most dangerous knockout, which can lead to the TMDs, definitely. Disturbance of vision, this is just associating feature. Swelling on one side of the face if the patient is suffering from severe inflammation. Facial joint pains on chewing or yawning, this is basically due to the disc derangements. So these are the basic 13 knockout features which when we encounter in the clinics, and we should be aware that yes, there is something mishap happening in the temporomandibular joint which has led to these features. Now proceeding on to how to diagnose. This is a very simple diagnostic mechanism which we should follow when we encounter patients having any one of the or any two of the diagnostic 13 knockout features. First and foremost is the clinical screening of the patient. Proper medical history of the patient should be encountered, because medical history would take us to a path and would also make us understand the clear truth, the medical history, the endocrinal condition of the patient, the hormonal imbalance, the stress if the patient is suffering from it, and then we could definitely help the patient in the proper diagnostic treatment, giving the proper diagnostic treatment. Intraoral examination, of course, is very necessary, because as I've already told about the different concepts given by the ancient medical specialists, by Dr. Gelb, by the natological concept by Jankelson, we understood that intraoral examination is very necessary, because occlusion is the first feature which would definitely lead to TMDs. Of course, head and neck neurological evaluation, which somehow or the other is responsible for TMDs, and not responsible for TMDs, but it would knock out and it will actually make us aware that it's not a TMD if we properly evaluate the head and neck neurology, because there are differential diagnoses of TMDs as well. Facial pain could also be due to trigeminal neuralgia, glossopharyngeal neuralgia, or any sort of neuralgic pain which the patient might suffer. So proper prompt head and neck neurological evaluation is necessary to actually rule out whether it is a TMD or not. And of course, the psychological testing is very necessary. We often encounter patients suffering from stress, anxiety, and they encounter TMDs. It's a very common feature which patient pops up into either burning mouth syndrome or TMDs. I have had patients who had definitely been suffering from either TMDs or from burning mouth syndrome, which I have encountered because of stress. And I have encountered patients who just because of stress were suffering from this pain. When they were given proper psychological therapy, when they were referred to a psychiatrist, they had got relief. And simple NSAIDs, that is my non-steroidal anti-inflammatory drugs, have helped them to get cured of TMDs and pain. Of course, when these don't work and we cannot come to a prompt diagnosis, imaging is the last sort of option. I would be naming a few imagings and few appliances and digital appliances as well, which would help us find out the exact cause of TMDs. This was the verdict which TMJ received. It's not a disorder of a single cause. Like it's saying on the slide, it's a disorder of the single cause. No, it's a multifactorial etiology. It has a multifactorial etiology, multifactorial causes. So it's not a disorder of a single cause. Occlusion is the basis of diagnosis. It's not exactly the occlusion, but yes, partly correct. Occlusion is basic, but there are several other features which are involved and help us diagnose the TMDs. It's not just the dental-based model, as already been said. The final verdict states that it's not just the dental-based model. These are not the considered facts. It's the muscular model, the nathological model, the occlusion, the craniomandibular model, which all are responsible for the diagnosis of the TMJ disorders. Then we have the position of the condyle, not the position of the condyle. Yes, the position of condyle is responsible, but the occlusion, the working of the patient's mouth, the muscles which help the condyle move, all are responsible. Centric slides cause TMD, not the centric slides only. The eccentric movements, they are responsible for causing TMDs. Anterior repositioning can capture the disc. Anterior repositioning, yes, of course, captures the discs. The disc is definitely anteriorly displaced in cases of clicking when we encounter the disc derangements, the disc displacement. But posterior repositioning can also lead to some of the other sort of disorders. Then if it matters, it definitely produces controversy. Now we have variety of treatments which we come across. We have the psychological approach, as it's not just the controversy in the etio-pathogenesis, or not a controversy just in the diagnosis. We have the treatment controversies as well. We have vast number of treatment modalities which help us get rid of the temporomandibular joint. We have the psychological approach. We give the patient self-management, cognitive behavioral therapy, arthroscopy, which definitely is a diagnostic help for managing the TMDs. But yes, they are used to remove the scar tissue or extra cranio or extra cartilage growth through arthroscopy. We have education and self-management in the physical therapy. Electrotherapy, which is very commonly given, the transcutaneous electric nerve stimulation therapy. We have surgeries, medications also, which help us get relief from the pain. Odontology, that is the occlusal model. We give the patient different occlusal clearing appliances to the patient, which help us get rid of the TMDs. Anterior replacement devices. We have intraoral orthopedic devices. We have occlusion treatments, brain training, arthrocentesis, neuromusculoskeletal physical therapy, and dry needling acupuncture. These are the different modalities which help us get cured of MPDS especially, and also various temporomandibular joint disorders. So now these are the pains which the patient might be reporting. We can have masticatory pain during the mastication. The patient might have cephalgia, that is pain throughout the head, skull. We have the Eagle syndrome, that is the elongation of the styloid process. We have the other facial pains, glossodiarrhea. It's also a common feature, which is due to the stress, basically, trigeminal neuralgia, the differential diagnosis. The retrodiscal pain, when there is elongation or inflammation in the retrodiscal tissues, which is very much overlooked by the dentists and the specialists. The Sjogren syndrome also can give the associated pain to the TMJ. Arthritic pain, it could be osteoarthritis, rheumatoid arthritis, psoriatic arthritis. Capsular pain, elongation or inflammation of the capsule which surrounds the TMJ capsular tissue. Bulimia nervosa, of course, it is one of the most underlooked and overlooked cause. But yes, it can also lead to TMJ, and it is actually a differential diagnosis, because due to bulimia nervosa is basically due to stress-related issues, and the patient might suffer TMJ pain. This has been described in several books, even in Bell's orofacial pain book, leading to temporomandibular joint disorders. Otalgia, patient might have ear ache, ear pain, glossopharyngeal neuralgia, traumatic neuromas. So these are all the pains which are associated along with TMJ, which might confuse us, leading into a controversy. So it's all in your head. So let's find out, are you still on a battlefield? Let's make it a quite easy topic, and let us classify the pain and help getting it diagnosed easily. It could be ligamentous pain, it could be capsular pain, retrodiscal pain, arthritic pain, masticatory pain. So these pains were actually given by Sir Bells in the book of orofacial pain, and he tried to make us understand and make it quite easy for us to diagnose the temporomandibular joint pain or the facial pain which is related to the temporomandibular joints. So how to understand? So I would be just giving a few features which might help us catch the pain, cause of the pain, and get it cured easily. If it matters, it definitely produces controversy, as said by J. Green. So we should first find out what is the cause of the pain and why the pain is happening, so that we can get into a prompt diagnosis and give proper treatment to the patient. So first and foremost is the capsular pain. So as we all know, temporomandibular joint is surrounded by a capsule. So TMJ capsule, and there are several cases when we come across the patient having capsulitis. There are inflammatory processes which might hurt the capsule, and these inflammatory processes can lead to exaggerated pain. It can only not be confined to one area, but yes, definitely it can radiate the pain to different regions as well. So the classic feature when we talk about capsular pain is when the patient is having pain during opening and closing of the mouth. The patient might have swelling, might have fever, associated features, and there is pain during opening and closing of the mouth, because when the opening and the closing of the mouth happens, the capsule and the ligaments, they get stretched. And in this type of pain, it is only confined to the time when the patient is causing the movement of the temporomandibular joint, not in the cases where the patient is actually in a state of not performing any activity, or it's in a very static position. It could be capsulitis, it could be also be synovitis. It's an inflammation of the joint area or the synovial joint area. This in type of inflammation has a great classic molecular level of pathogenesis, where we find molecular chemical mediators playing classic role, like the prostaglandins, interleukins, and osteoclasts. These play a very classic role, and it should be controlled at the very initial stages, otherwise it might lead to great issues with the joint. So it could be masticatory pain, ligamentous pain. These are the differential cases: masticatory pain, ligamentous pain, synovitis, or it is either capsulitis. Now, how to differentiate among these? Next is the arthritic pain. This is basically arthritis, and there are three basic type of arthritis which are encountered in the temporomandibular joint area. It can be psoriatic arthritis, it could be osteoarthritis, it could also be a normal rheumatoid arthritis, which patients suffer. So when I talk about arthritis, patient might have continuous pain. Osteoarthritis has a classic feature. It can occur bilaterally or of course unilaterally as well, but basically it occurs bilaterally. Rheumatoid arthritis can also affect other joints of our body. So we can easily classically find out that yes, other joints are also involved. We can easily get to a simple blood investigation for finding out the rheumatoid factors, giving us a prompt diagnosis of the arthritic pain. And the pain on this type of patients who have arthritis is very cranky type of pain. We also can hear crepitus sounds sometime in cases of arthritic pain. And the patient, when on opening and closing the mouth, can give us a type of the classic liquid movement in the temporomandibular joint area, which we term it as crepitus, or eggshell cracking type of noise on opening and closing of the mouth, which can lead us to a prompt diagnosis that it's definitely an arthritic pain, and we can proceed forward accordingly. These are the features associated with arthritis. It could also be involving different areas of the body: headaches, eye, mouth disorders, teeth, of course, clenching type, throat issues, laryngitis. Patient might also suffer from laryngitis and other inflammatory situations in the mouth. There might be neck problems, jaw problems. Then we have ear disorders as well, as the inflammation might spread to other associated structures also. We have osteoarthritis, rheumatoid arthritis, degenerative joint disorders, periarticular inflammation, as already said. And these are the differential diagnoses which might be taken into consideration if we encounter a patient like this. Then we have the ligamentous pain. So it's quite very difficult to differentiate between the ligamentous pain and the capsular pain. The basic diagnostic modality which helps us find out is the arthroscopy and arthrocentesis as well. In the cases of ligamentous pain, the patient might get pain during the stretching of the ligaments, or there might be derangements as well inside the joint, which could easily be felt by the physician on palpating the temporomandibular joint and checking for intraoral or oral examination. We can easily check the temporomandibular joint by the extraoral and intraoral examination. We can easily find out whether it is related to the articular disc and the ligaments or not. And the patient definitely has pain during opening and closing of the mouth when the disc gets deranged. It could either move ahead of the joint. It could either get pushed back. There could be posterior derangements. It could be anterior derangements. It could also be displacement. It could also lead to dislocations. So in this type of ligamentous pain, when the patient is commonly encountered in these cases, we should definitely think how to cure the particular disease by giving either muscle relaxants, or if the case is quite worse, we can proceed with surgeries and other treatment modalities. The most challenging and unforgotten cause of the TMJ abnormalities is a trigger point, that is a retrodiscal tissues. This is actually a most underrated cause, because being dentists, when we used to study in the initial BDS also in our first or second years, we never used to encounter and go in depth of the retrodiscal tissues. But yes, retrodiscal tissues are very necessary because these are the tissues which actually provide blood supply and keep the tissues vital in the temporomandibular joint. And it is very easy, and it's like chances are quite high that these tissues can get irritated and inflamed. So retrodiscal pain is actually a pain which a patient suffers only during opening of the mouth. When we open the mouth, patient suffers retrodiscal pain, because in that case, when the tissues are inflamed, they won't pull back the retrodisc, they won't put back the articular disc and help in closing of the mouth. Instead, they get more triggered and they cause pain to the patient. So retrodiscitis or retrodiscal inflammation is one of the major causes of temporomandibular joint pain, and it is also one of the most confusing causes, because in these cases we might land up thinking that it's ligamentous pain and we can proceed with different modalities, giving muscle relaxants to the patient or non-steroidal anti-inflammatory drugs, but we have to cure the actual cause. So it could be inferior lateral pterygoid muscle pain. It could be hemarthrosis, which is leading to ankylosis and also irritating the retrodiscal tissue. Disc attachment pain due to orthodontic instability. It could be synovitis as well, which could lead to retrodiscitis and retrodiscal pain. So treatment is not the same for all. Treatment is not the same for all. We have to proceed accordingly, finding out the exact cause to be retrodiscitis or retrodiscal inflammation, and then proceed with the treatment modality. So no more jaw clicks. I hope I have made people understand how the etiology is different in every case, how many treatment modalities are there. So finding the cause out is basically the difficult task. And once we find the cause out, we can diagnose the case easily and also can move for the treatment modality easily. So no great advancement has ever been made in science, politics, or religion without controversy. As given by Lyman Beach, I would like to end up my presentation stating that it's a controversy, but it can be cured definitely. Thank you. So I would like to answer a few questions. Yes. Ma'am, if mouth opening is due to TMJ disorder, what precautions should be taken? Yes. If mouth opening is due to TMJ disorders, we should first find out what is the cause of the TMJ disorders. Yes. So if we find out the cause of the TMJ disorder, whatever the cause is, as I already said, if the mouth opening is reduced due to TMJ, there might be some issues related to the joint. It could be ankylosis. So you have to line up with that. You should find out the first medical history of the patient, because ankylosis is usually when the patient encounters any accident or trauma and he doesn't get cured. Because in my 4 years of experience, I found out that there was, I have got in ankylosis patient. I even have worked for their surgeries also. I've done the surgeries as well, the condylectomy surgery. In that case, I found out that was basically a patient who had trauma, an accident 3 years back, and then he was not giving heed to whatever was happening. And in the end, he landed up with mouth opening of just like 9 mm. If the mouth opening was like 8 to 9 mm, and then we cured the patient. We did unilateral condylectomy, and temporalis myotomy was performed, and the patient after 2 months, yes, after 1.5 months or 2 months, was able to open the mouth, and his mouth was, his mouth was opening around, mouth opening was around like 25 to 28 mm. So the patient was very much satisfied with whatever we did. Okay, what are the treatment and medications for reduced mouth opening due to TMJ disorders? See, reduced mouth opening, how to palpate TMJ musculature. First, we should know how to palpate the muscles of mastication. We have different intraoral and your extraoral methods of palpating. I would like to definitely share a few